Arvind Kumar from Hyderabad AIMS, who will tell us his brand ambassador without any without financial interest. It will be in DSTC. I have to carry it because I didn't bring my manager also with me. So I have to carry it to DSTC, the orthoptech. There you can sit down and talk any number of questions you have, you can ask. But they charge you 1,000 rupees, which will be refunded after you buy the orthoptech. That is another incentive for you to come and use it and see it. If you can't come today, no problem. Saturday there are 2 sessions between 10 and 12 and 2 and 4 in the same DSTC area. Arvind.
Yeah. Good afternoon, everyone. And thank you, AIOS and Dr. Santhan Gopal sir for giving me the opportunity. So I will be speaking on all about amblyopia, the metamorphosis and the vacillation, the changes going on, the different modalities of treatment coming up because patching is quite outdated now. So we have compared different modalities of these amblyopia management. So vision without action is merely a dream, and action without vision just passes the time. And vision with action can change the world. So it is by Joel A. Barker, and I'm thankful to all the Indian innovators who have done a lot of things in the world of ophthalmology. So what is the definition of amblyopia? It is the unilateral or less commonly bilateral reduction in the best corrected visual acuity that cannot be attributed directly to the effect of any structural abnormality of the eye or the posterior visual pathway. And there needs to be at least a difference of 2 lines in the logmar. So does it require redefinition? Yes, it requires redefinition as the alpha and the sigma female gems bond. So amblyopia definition needs to be changed. Which factors needs to be reconsidered? So excluding all other causes for the visual acuity reduction and cerebral changes, defining the functional blood oxygen level dependent MRI, methods of management, and the combination of treating modalities. Why we are sticking to a one treatment modality when we can combine 2 different modalities and get good results? So these are the other factors: eye-brain ability to process the motion, shape perception, spatial interaction, hyperacuity, contour integration, and the binocular single vision components. So we did the world's first such clinical trial on phakic IOL versus Occlutep versus orthoptech in children and adolescents for management of amblyopia registered with ICMR. So occlusion therapy is a problematic, as sir has already discussed. So recurrence is also there. So then this Occlutep is there, that is a binocular polarized video games. So same background but enriched foreground to the amblyopic eye is given. And based on the principle that they can strengthen a broad range of visual tasks in adults with normal vision, including light sensitivity, contrast sensitivity, visual crowding, and visual attention. So this is how it is done. The enriched foreground to the amblyopic eye is given, and the games, they have a stepping up. So first they are very slow, and then later on they are fast engaging games. Then comes the latest, the orthoptech magnocellular stimulator. So this instrument has 3 rows of light LED, and central one is red in color. And the light come on and off for 150 to 200 milliseconds. And the patient fixates with the help of the green laser and points at it with a laser pointer. And the patient needs to be seated at a distance of 1 meter from the machine, and the procedure is conducted for 30 minutes. It requires very less time. So 30 minutes a day, not a problem. So these are few videos. So this is how it is done. So the patient is asked to follow the flashing of the light. The central one is the green, and the rest of the lights, LED lights, they are red in color. So to analyze the demographics and the clinical outcomes of the phakic IOL versus Occlutep versus orthoptech in the management of anisomyopic and isomyopic amblyopia in the age group of 10 to 19 years. So it was a prospective international study, and 69 eyes of 63 anisomyopic and 3 isomyopic amblyopia patients were randomized in 3 groups: Group A phakic IOL, Group B Occlutep, and Group C orthoptech. And the patients were followed up at day 1, 6 weeks, 3 months, and 24 months after treatment. So these were the results in demography. So from 10 to 17 years, there were 69 patients in all, and with equal female to male ratio. So in the group A, the Fekhi-Kyle group, from the preoperative, the mean and the standard deviation of the preoperative vision uncorrected to the last visit in the group A, so there was a significant p-value from 1.39 logmar to 0.11. In the group B occlu tube, 1.35 logmar to 0.11 logmar. So in all the three groups, vision improved with a significant p-value. In the orthoptech group, it was 1.37 to 0.11. Now coming to the comparison of the contrast sensitivity between pre-treatment to the post-treatment in three groups. So 1.07 in the A group to 1.66. In the group B, 1.1 to 1.65, and it was highest in case of orthoptech from 1.09 to 1.98. So there was a significant p-value as we compared the orthoptech group along with the occlutab and the Fekhi-Kyle group. As we compared the stereoscopy, again it was more rapid in the orthoptech group, and it took largest time, much longer time in the group A, that is Fekhi-Kyle, to improve the stereo acuity. So in the conclusion, the amblyopia is a brain abnormality. It's not only an eye abnormality. So this are the functional bold MRI pictures. So in the first picture is a normal patient without having amblyopia. And the next, the MRI is of the amblyopic patient. So there is reduced oxygenation and blood to the occipital cortex. And after orthoptech and occlutab treatment, the blood, there was improvement in the oxygenation and the blood levels. So how it happens? So repeated stimulation of the magnocellular cells. So they have 4C alpha at the V1 area, and the saccadic and the attention area, they work opposite to each other. But they have horizontal interconnection. So by this way, the magnocellular, the peripheral cells, they stimulate the 4C beta. 4C alpha stimulates the 4C beta, and that's why the prosaccades are associated with maximal stimulation of the V1 area. So in conclusion, orthoptech magnocellular stimulator is a novel economical instrument in the management of anisomyopic and isomyopic amblyopia in terms of faster improvement in contrast sensitivity and stereo acuity, and multicentric clinical trials are of course needed in other amblyopia, and there are 11 other indications of this machine. So future is absolutely combination of different methods of management of amblyopia. So now what we are doing a new study, so we are implanting Fekhi-Kyle, and then we are going for occlutab or orthoptech. So those patients are improving very well because you don't have to worry about the glasses anymore. Thank you so very much. And this was a case, 56-year-old, the right eye, the refraction of plus 2.5, 618, and left eye -1, diopter to 6/6. The contrast sensitivity was 0.35 and stereo acuity more than 800 second of arc. So he did the exercise, and after 1 week, the vision improved to 6/6 part, 56-year-old patient. This is the after treatment. He is reading 6/6 partial line, logmar chart. Okay, they haven't connected the voiceover. And the contrast sensitivity improved to 1.25. Stereo acuity from more than 800 second of arc improved to 70 second of arc. And patient is so happy. He has undergone 24 sessions now. And after 6 months, there is no recurrence.
Very good.
Yeah. So thank you so very much.
Thank you, Arvind, for that wonderful explanation with no financial interest.
No.
There is no financial interest whatsoever in orthoptech. He is propagating the scientific truth. The scientific truth, like anything else, initially is rejected completely, then accepted by a lot of people, then rejected by a small number, and then it stabilizes at some stage. It goes through a graph. So the first thing, their reaction is it really true? I have never seen this like before. But the answer is yes, because you have never done this before. Why I didn't do before? Because I had too many headaches of dealing with so many things in life. Once I retired from AIOS, I had time to, then questions start coming. Why is this so? Then you have to read. So it took me about a year for me to understand the vision properly. What exactly happens? So there are certain points these people have mentioned. One, a rapid improvement. Number two, non-improvement also they have mentioned. And number three, patients are subjectively very happy after 2 sessions of orthoptic treatment. Why the patients feel happy? Why it does not improve? And why the rapidity of improvement of vision? These are the 3 things I am going to tell you.